and ask them to join by that time.
Definitely, sir. So 5 seconds, good to go.
Okay. Yes. Good evening, friends. Good evening, all. Dr. Rajendran here, your surgical gastro faculty in DocTutorials. So difficult to recall we always have is to recall the surgical gastro questions from AIMS question, because the first important difficulty we face every time is to collect the questions. To collect the 80 questions is always a tough task for us. Very few students give the questions what they do in the exam. And second important is to find out the references and go through the exact choices will take so much of time. So that is the reason for the delay. And also we used to do the recalls just 1 to 2 months before. One thing I can only as such is the most demanded specialty in INI. In INI SS, if you see, the most demanded exam paper is surgical gastro. And usually there will be no repeat of questions. This I want to tell you always, because many times students will be thinking there will be so much of repeat questions, etc. But we have never seen repeat questions in any of the past 3 years. The concepts may repeat, but there is no ditto repeat question, no ditto repeat choices are seen. And all the questions we see in this exam are only from Shackelford and Sabiston. Recently, we are not seeing Bloomgard questions also much, but most of the questions are from Shackelford and Sabiston. But Bloomgard, you can touch up the areas as per Dr. Santosh Anand sir, who is going to join next. He'll be teaching you the HBP repeat questions. So let me start with the GIT gastrointestinal luminal tract questions, starting with esophagus. As you all know, esophagus is usually the high yield area in INI, but this time they didn't go into the esophagus much. Only few questions are asked, and that questions also you can answer based on Sabiston itself. Caustic injury of esophagus and stomach. So welcome all, Swapnil, all of you, welcome. So any doubts you can post in the chat box. I'm watching the chat box in YouTube. Caustic injury of esophagus and stomach. 3 days back, patient comes to you now with the respiratory distress. Best investigation to do a proper evaluation, staging, and management. See, the best investigation for a corrosive injury, first of all, you should know, if they ask you without any details, corrosive injury, the best evaluation is always with the help of upper GI scopy. As you all know very well, upper GI scopy in a corrosive cases should be done within 24 hours, ideally. It doesn't mean we should not do after that, but if you are going to do after 24 hours, we should use careful pediatric scopy and careful insufflation. That is very important. But ideally, it is done within 24 hours of corrosive cases. And the grading we get is Zargar grading. That is 1, 2, 3, 4. The answer for this question is not endoscopy. Just I'm telling you what is commonly used. Number 1 is erythema, 2 is ulcer, 3 is necrosis, 4 is perforation. So ulcer can be superficial ulcers or deep ulcers. Necrosis also can be scattered necrosis, and it can be a diffuse necrosis. So this is a simple, in this cases, we always discuss in our classes. This is 3A, okay? This is 2A, 2B, 3A, 3B. In these cases, who will need careful admission and observation in ICU are 3B and 4 will directly go for surgery. Please don't forget, they will go for surgery. Directly, we have to take them for surgery because they are emergency. They are going to go for so much of sickness. So 2B and 3A will be managed in SICU. 2B and 3A will be managed in SICU. 1 and 2A will be managed in a general ward. They can even start oral fluids. Okay, they can even start oral fluids in 1 and 2A. But this is a basic outline of Zargar grading. But this question is very classically linked. The patient is having respiratory distress. Respiratory distress in a corrosive ingestion can be due to many causes. One of the causes, injury of the larynx or esophageal perforation. So there is high chances of esophageal perforation, which would have happened. In such cases of patients who are coming to you with a respiratory distress, upper GI endoscopy may not help you to properly evaluate the thoracic problems also. So I will go with this answer on CECT, thorax and abdomen. That will be the best answer for this. So CT imaging done within 72 hours of injury was used to assign a grade to the esophageal wall. There is a grading given in Shackelford page number 47 for CT grading also. The grading system was designed to predict subsequent development of a stricture as documented on esophagram, and another study looked at 3B injuries on endoscopy. So definitely this case is a case of either 3B or 4. So therefore for a 3B or 4 case, better answer is to go for CT scan. A systematic review of the literature noted a lack of randomized control data, but concluded that CT cannot replace endoscopy overall. Essentially, literature supports CT imaging as an useful adjunct to endoscopy in guiding management of dynamically stable patients. Okay, in a stable patients, we can use CT scan as an adjunct. Okay, whatever this is, the grading given in Shackelford, please see the grading. Grade 1 is no definite swelling of esophagus, wall less than 3 mm within the normal limits. Grade 2, more than 3 mm without peri-esophageal soft tissue infiltration. Grade 3, peri-esophageal soft tissue infiltration plus well-demarcated tissue interface. And grade 4, edematous wall thickening with a soft tissue infiltration, blurring of tissue interface, or localized fluid collection around the esophagus and aorta. All these are going for clue of perforation. So grade 4 can be a case of perforation. So this is a CT scan used for evaluating. So the simple question, how will you evaluate a corrosive patient with the respiratory distress? So both CT and endoscopy can be done. Since there is a wording on respiratory distress, we can go for CT, thorax and abdomen. Okay, that is the answer for first question. We have around 25 questions from 20 to 25 questions from GIT. Let us see one by one. This is a classical INI question. In a INI SS question, this is a typical question. Esophagectomy for cancer esophagus, identify the node in the image shown below. This is a classical image of video-assisted thoracoscopic esophagectomy or a open thoracotomy surgery shown here. I don't know which image they gave in the exam, but nowadays this procedure is done by VATS, video-assisted thoracoscopic surgery, removal of the nodes in the chest. That is the procedure. So can you see what node they are marked as? This node. This is a classical picture showing you bifurcation of trachea. This is answer for this question. So the node asked in exam is 1 or 7 node. That is a point I want you to remember. So the node asked in the exam is 107. So 107 node from Shackelford, you can see. But the point is the Shackelford did not give Japanese classification of nodes. This question asked on Japanese classification. This is not asked from Sabiston, Shackelford. So this is the table from Japanese. This is a table from Shackelford. In this table, if you see, they didn't mention the Japanese grading. What is there in Shackelford is American Committee AJCC staging. In that, the same node is 7. 7 is the subcarinal node. But please remember, the same MCQ only asked already in few exams before, some 3 years back, 4 years back, the same question. The node, subcarinal node, 7th node is asked in the exam. 7th node. And we cannot remember every number of nodes, but 1077 and 7 is the Japanese is 1077. But Nikhil Tiwari, but did they ask you about the nerves? But because this is, yes, if they are asking any nerve related query in this anatomy, recurrent laryngeal nerve will be coming in this. So recurrent laryngeal nerve can be asked in the VATS image. But since I had a recall the node shown in the image, I was going with the 107 node, subcarinal node. So recurrent like this, I request you please go through this VATS image. The next exam question will be based on And the images on VATS, what are the structures? For example, in a VATS, you will be asked about azygous vein also. Azygous vein image can be, because now recently all the esophagectomy and nodal dissection are done by video assisted thoracoscopic surgery. So you might be able to identify recurrent angina, azygous vein, and 107 subcarinal node. So these three anatomies can be asked in the exam in a image-based question. So there is a nerve visible. Okay, there is a nerve visible. If they have pointed that nerve, that is only recurrent angina. There is no other nerve will be which is prominently visible. So phrenic nerve and all will be not coming such a low level below level. So if there is a node nerve visible, it will be recurrent node. Okay, 107 node is American Joint Cancer Committee node 107 node. This question is a favorite question already asked in AIIMS exam. Subcarinal node is 107 in Japanese and 7 in American Joint Cancer Committee. Okay. Some questions of gastro questions look like general surgery questions because 80 questions, whatever is asked as G80 questions I have taken, including general surgery also, these questions might have been asked. Chest pain radiating to the limb, barium study show corkscrew esophagus. It's a very simple question. Probably is a general surgery part question. This is diffuse esophageal spasm. On a barium swallow, in a diffuse esophageal spasm, we have a classical corkscrew appearance like this. This is diffuse esophageal spasm. In nutcracker esophagus, we see what finding? In a nutcracker esophagus, we see these epiphrenic diverticulum. Okay, in a barium swallow, you can see epiphrenic diverticulum in nutcracker. So the two hypermotility disorder in nutcracker, you will get epiphrenic diverticulum seen on barium swallow, and in diffuse esophageal spasm, you get the typical corkscrew appearance. Okay, it's a typical corkscrew appearance. Only 3 questions came from esophagus, so not more than 3, and also the 3 questions are straightforward questions, not so difficult also. Just kit represents what? In just kit represents, I think this is also a general surgery part of question because I don't think national board examiners will be asking so simple question of tyrosine kinase receptor. Just kit represents tyrosine kinase receptor. The point I want to remember here is C kit is CD117. It is gain of function mutation. Okay, not loss of function. Don't forget this point. So gain of function mutation. There is a detailed explanation of all the genes from Shackelford. So CD117 protein, which is a tyrosine kinase receptor known as KIT, was a critical step in better classifying this tumor. So just arising from interstitial cells of Kajal, which also expresses CD34 and CD117. This is a gain of function mutation leading to increased activity of KIT tyrosine kinase receptor. And some lesions may also develop gain of function mutation in, please note, it is also seen in PTGFRA. PTGFRA is also a gain of function mutation. And it is seen in 10% of the cases. PTGFRA is seen in around 10% of the cases. CD117 is now primarily used as a criteria for diagnosing just PTGFRA is also CD117 is primary. PTGFRA is seen in 15%. When both of these CD117 and PTGFRA both are negative, we call it as wild type GIST. So wild type GIST is a GIST with no tumor marker positive. CD117, PTGFRA both are positive, and new tumor marker which is used now is DOG1 as an overall sensitivity of 95%. So sensitivity of DOG1 is around 95%. So please remember this point. Okay. Yes, anectomin is also a tumor marker, but here this question is asking just KIT represents tyrosine kinase receptor. So there are so many tumor markers, but please don't forget this. So anectomin is another tumor. So what are the tumor markers? Anectomin. But Shackelford is not discussing about anectomin. CD117, CD34, PTGFRA, DOG1. So many tumor markers are there. In this, 95% will have anectomin, 95% will have CD117, 95% will have DOG1. Don't forget this point. Sorry. Yes, the anectomin is also positive, but it is not there in this. And this question is a classical, and this question and this concept is repeated multiple times. Which of the following is not high risk factor of feature of GIST? Which of the following is not high risk feature of GIST? So this is according to modified Joensuu criteria. I always ask you to remember modified Joensuu criteria. That is, tumor size more than 10 centimeter is high risk. Okay. Tumor size more than 10 centimeter is high risk. Mitotic index more than 10 out of 50 high power field is positive. Non-gastric site is high risk. So in modified Joensuu, don't forget these 4 points. Tumor size more than 10 centimeter, mitotic index more than 10 out of 50 high power field, non-gastric site, and last one, ruptured GIST. These are coming under the high risk. And fifth one, if you want, you can add up. That is very important. Size more than 5 centimeter and mitotic index more than 5 out of 50 high power field. So these are the 5 factors which are having very important point. These are, thank you, Dr. Adit sir. Thank you. This is modified Joensuu criteria. So which is not high risk. In this picture, if you see B, less than 5 centimeter, more than 5, it is not high risk. 5 to 10 centimeter with a non-gastric, it becomes high risk. Non-gastric, all will become high risk according to this table. So this is a table from Shackelford. Please don't forget the table. Non-gastric is any non-gastric is high risk. Tumor rupture becomes high risk. Size more than 10 centimeter becomes high risk. More than 10 mitotic index becomes high risk, and more than 5 also becomes high risk. So just remember the high risk alone. Every time they ask you this high risk features of modified Joensuu criteria. Now coming to small bowel. So only 2 questions came from stomach chapter. Then coming to small bowel chapter. So I always tell when you are reading small bowel chapter, the one topic you should never miss a single line from Shackelford is Peutz-Jeghers syndrome. So Peutz-Jeghers syndrome is a favorite topic of National Board examiners. So all are true about Peutz-Jeghers syndrome, except, so the polyps seen in Peutz-Jeghers syndrome are hematomatous polyp, and the most common cancer seen in Peutz-Jeghers syndrome, is it small bowel cancer or anything else? It is autosomal dominant. It is STK11 mutation on chromosome 19p. The commonest cancer seen in these patients is not small bowel cancer. It is colon cancer. They get variety of cancers, but colon cancer is the most common cancer. So please don't forget, Peutz-Jeghers polyps have a characteristic appearance on pathology. What finding? On pathology, they have a characteristic appearance, that is, the tumor, the polyp arises from which layer? Origin is from which layer? Usually, all the polyps arise from lamina propria. This is the only polyp arising from muscularis mucosa layer. Muscularis mucosa layer, not from lamina. All the other polyps arise from lamina propria. The one which has polyps arising from muscularis mucosa, since it is arising from such a deeper layer, the amputation or a self-amputation of the polyp will cause so much of bleeding. So bleeding is one of the presentation of PJS polyps, and they have an arborizing pattern. Arborizing pattern on pathology. So to say it is a Peutz-Jeghers polyp, the hematomatous polyp, it should have arborizing pattern and origin from the muscular mucosa. So PJS is diagnosed using a criteria by WHO more than or equal to 2 Peutz-Jeghers polyps. What is Peutz-Jeghers polyps? Those arise from muscularis mucosa having a arborizing pattern. More than 2 polyps, at least 1 polyp with a family history. See, 2 polyps or 1 polyp with a family history, or no family history also, but that is a classical finding of mucocutaneous pigmentation. Even if there is no polyp, see the last line very important. In the absence of PJS polyp, a diagnosis can still be made if there is a family history of the disease with the typical pigmentation, even if there is no polyp. So PJS can be diagnosed. Yes, very good, Ankit, that is correct. Even without a polyp, we can say PJS by seeing the pigment and as many as 50% of the affected individuals are new people with a repeat incidence of 1 in 1,20,000 live birth. It is STK11 mutation, chromosome 19. Polyps can happen anywhere. Small bowel is the most common site of polyp involved in 75% of the individuals. Polyps can also happen in colon, 42%, stomach 38%, rectum 28%. So lesions, less common locations of tumors include respiratory tract, biliary tract, urinary tract. Other characteristic finding of PJS is pigmented melanin macules on skin or mucous membrane seen in 95% of the patient. Lips and perioral in 9 most affected. The intensity of the macules from infancy, it often slowly fades. So increase in infancy and early childhood, but in adults, if you go and see, the macules disappear, whereas pigmented spots on the buccal mucosa are present in 2/3 of the individuals. But unlike skin macules, buccal lesions, please don't forget this point. So this is a very interesting point. The pigmented spots, not macules, pigments are present lifelong. Macules disappear in adults. So macules disappear in adults, pigments present lifelong. So 1/3 of the PJS patients become symptomatic during the first decade of life, and they come to you because of intestinal obstruction due to interception by the polyps. So the most common presentation is pain due to interception. So recurrent obstruction requiring re-laparotomy is common and is performed in between 1 to 4 times per patient. So polyps can cause bleeding due to amputation and can go for iron deficiency anemia, and the age of death of these patients is usually younger than 38 years. The age of death in a typical family member is 38 years when compared to the unaffected members 69 years, and was usually due to intestinal obstruction and cancer. So the point I want you to focus in this topic is the cancers. There are so many cancers, both GI and non-GI. See the list of cancers. In intestinal cancers, the most common location is 36% pancreas, stomach 29%, small bowel, though the polyp is number 1, it is in 4th place. Even esophageal cancer are seen. So non-digestive organs, breast is the most important cancer site. Ovary 21%, lungs 15%, uterus. So cancers of biliary tract, gallbladder, unusual genital tract tumors, ovarian tumors, testicular tumors, all are seen. Okay, large cell calcifying cellular tumor. All these are seen. I'm telling you, please go through this Peutz-Jeghers syndrome thoroughly. So PJS is a very important topic for your exam, especially for INI SS. PJS, the examiners will be always focusing. So I can tell in small bowel, 2 chapters every year question come. From PJS, another is from short bowel. See short bowel syndrome, 1 question. It's a favorite topic of INI SS. And all the short bowel syndrome topics you should read only from Shackelford. PJS and short bowel syndrome, both please read from Shackelford. In short bowel syndrome, after surgery, patient goes for short bowel syndrome. Acute phases for 4 weeks. Adaptation phases begins after 1 year. Maintenance phase is long year. Adaptation begins from 24 hours and continues for 2 years. So adaptation phase begins after 1 year is wrong. It is not 1 year. It starts very soon. It starts very soon, not for after 1 year. So intestinal adaptation is a mechanism of GI tract functional recovery that occurs after resection state of short bowel syndrome patients. This adaptive process, the first step is adaptive phases that occurs within 24 hours and continues even up to 2 years period. The degree of success of intestinal adaptation depends on anatomical factors such as extent and site of resection, patient's health, underlying disease, nutritional support, everything acts on this. So Keller has identified 3 phases. Acute phase is up to 4 weeks. Adaptive phase starts immediately and can extend up to 1 to 2 years. Maintenance phase is long time. So what is happening in each phase? Acute phase, the goal is stabilization of patient's diarrhea, malabsorption, and dysmotility. That is our aim. Adaptive phase, our goal is to increase the nutritional exposure. Okay, our aim is to give the nutritional support. Maintenance phase, optimizing fluid balance and individualized diet regimen and management of any acute exacerbation is needed. Acute phase is marked by hyperemia of the bowel. So please don't forget, in acute phase, there is a hyperemia of the bowel. An increased blood flow to the remnant intestine may be seen up to 4 weeks. So hyperemic changes promote mucosal hyperplasia with resulting increased number of size of crypts in the villi of ileum. So this is very important point. The hyperemia helps in multiplication of the number of cells and size of the crypts in the ileum. So hyperemic changes are very important to have mucosal hyperplasia. Normal ileum is exposed to fewer luminal nutrients than jejunum. Taking advantages of the ileum's adaptive capability, please remember, therapeutic stimulation via planned and gradual exposure of macronutrients to ileal intestinal mucosa leads to a net increase in the absorptive surface area. Our aim is to increase the ileal surface area. Our aim should be totally to increase the ileal surface area. Intestinal wall lengthening, luminal diameter increase, wall thickening can occur in ileum. Such adaptive growth of intestinal length and diameter is more prominent in premature babies with the short bowel syndrome. After morphological changes that happen for 2 years, there is evidence of retention of these features. After this, there is a retention of changes. Jolie has reported 30% increase in crypt depth and 22% increase in cell numbers and crypts in type 2 jejunocolic anastomosis. All these classifications are there in Shackelford, type 1, type 2, type 3, type 2 jejunocolic anastomosis. You can see the multiplication of the numbers of crypts. Okay, don't forget this. Very important for your exam, short bowel syndrome, 3 phases: acute, immediately up to 4 weeks, adaptive phase. So the point is, in short bowel syndrome, ileum goes for adaptive replacement, in which there is multiplication of villi and multiplication of crypts. So this is a classical question from short bowel syndrome. In short bowel syndrome, there are so many questions from small bowel chapter. Crohn's disease patient with a morbid obesity, surgery of choice. This is, I don't know whether it is asked as a general question or as a SS question, but it is a very commonly asked question in NEET PG exam itself. Crohn's disease patients with morbid obesity, we cannot do any bowel touch. You should not touch the small bowel. You should not touch. You can only, because when you do sleeve gastrectomy, the stomach is preserved, so it can help you in absorbing the drugs and steroids. So the answer for Crohn's disease is sleeve gastrectomy. This is a favorite table of National Board examiners for NEET SS. So where all places you have potential role of laparoscopic sleeve gastrectomy. So the following cases, sleeve gastrectomy is best than any other disease. Number 1, you just know that this is iron deficiency anemia. Crohn's, transplant patients, cardiac patients. This is 3 reasons are to give drugs. We want to give drugs that should be properly observed in Crohn's, transplant, and cardiac failure. And patients on NSAIDs. So who cannot come for proper follow-up, already having vitamin deficiencies and connective tissue disorders. So in all these patients, always better to go for lap sleeve gastrectomy. So this table explains for lap sleeve gastrectomy in all those cases, yes, want to disturb the small bowel by any way. That's correct, Mohammed Hamza, correct. So please remember this table from Sabiston 1190. This is a new question. The first time we are seeing this question. Please don't forget this question. Which of the following is not true? Classical question related to chromogranin A. This is a question related to chromogranin A, 5-HIAA. So these are the 2 methods of diagnosing carcinoid tumor, neuroendocrine tumor, 24 hours urinary, 5-HIAA, and chromogranin A is a tumor marker. So these 2 points you should not forget, basic. So now this question focuses on 5-HIAA related points. So which of the following IAA? There are some drugs which alter 5-HIAA level. 5-HIAA sensitivity is 75%, specificity is 85%. Most specific is 24 hours urinary 5-HIAA. Hindgut neuroendocrine tumor have increased 5-HIAA than midgut. So please remember, the wrong answers here are A and D. So let us see the choices now. In patients whom other diagnoses have been ruled out, or in those who have likelihood of neuroendocrine tumors, particularly, we proceed with the first test is 24 hours urinary 5-HIAA. Sensitivity 75%, specificity 90% in this test. specifically foods with high tryptophan content, such as avocados, bananas, walnuts, are adequate preparation is needed. So they should be something they can alter the levels are high tryptophan content containing avocados, bananas, walnuts can alter the value. Some medications can disrupt the test, like falsely high values are acetaminophen, nicotine, and these are having false high urinary values. False low, this is what the question asked. False low in heparin, aspirin, and isoniazid will have low. So therefore, aspirin, if the patient is on aspirin, it can show you can decrease 5-HIA, not increase. So it can show decrease 5-HIA. This is a new question asked in the exam. So just remember, aspirin prophylaxis can show falsely low 5-HIA. Falsely high is seen in acetaminophen, guaifenesin, nicotine. Don't forget this question. So measurement of urinary 5-HIA is most useful for midgut tumors and less for foregut and hindgut tumors. So this is a straightforward question. So you all know midgut tumors only produce 5-hydroxytryptophan, serotonin, and all. So therefore, the end products of this is 5-HIA. Hindgut tumors, what is the substance produced by hindgut tumors? You know that well. What is the substance produced by hindgut tumors? Neuroendocrine tumors of hindgut, what do they produce? They produce, yes, they produce somatostatin and peptide YY. They commonly produce somatostatin and peptide YY. Hindgut tumors produce somatostatin and peptide YY. So the measurement of serum chromogranin is useful. This can be elevated in both functional as well as non-functional tumors. That this test is particularly sensitive to assay the technique, as it is advised that serial measurements can be performed. So chromogranin A can be elevated in many non-neoplastic causes like impaired renal and hepatic function, hypergastrinemia secondary to PPI or atrophic gastritis, and IBE. These are false elevations. Falsely, we can see elevated chromogranin A in some cases. So please remember this point. So don't forget, carcinoid tumor is another favorite topic of national board exams. So we always see some areas are focused by INI SS examiners as well as NEET SS examiners. One is carcinoid tumor, short bowel syndrome. Just all these are favorite topics. You should not forget these topics. And first time they are asking a question which is a suturing related question. Also, this question may be a general part question or also a SG part question, we don't know. But let us discuss. This is explained extraordinarily from Shackelford. Okay, let us see the pictures and then come back to the question. Okay, let us see all the pictures and then come back to the question. So see the question, number 1. This is interrupted Lambert and this is continuous Lambert. What is Lambert? Lambert is a seromuscular suture done over the previously done anastomosis. Seromuscular suture with the help of silk. Usually it is done with the help of silk. It can be interrupted or it can be continuous. Both can be accepted. So this is Lambert suture. Similar to Lambert suture, there is one another suture called as Halsted. It is also seromuscular, but what is the difference? It is also seromuscular. Can you see the Halsted? It is like a mattress. It is done like a mattress, skin mattress suture. No, why? Because seromuscular mattress suture. Because if I do interrupted sutures, the wall is not good, healthy. In unhealthy wall, you can cause trauma to the bowel. So in unhealthy bowel, I go for Halsted. In unhealthy bowel, when I take the suture, it will get teared up. So Halsted is used for unhealthy bowel. Please don't forget this point. Unhealthy bowel, we go for a Halsted suture. So Lambert, Halsted, both are seromuscular sutures. You should not get confused in that. So next, to Halsted, Lambert. Don't forget. Cornell suture. So next is Cornell. I hope most of you as surgeons would have done Cornell suture. Point to change from one side to other side. We go for a suture in which you can understand here. Go from outside to inside. The same side go from inside to outside. So same side go from inside to outside like this. So then you can come from outside. So changing from one side to another. So cornell suture is a corner suture. Remember like that. So cornell suture is a cornell suture which is full thickness continuous suture. Which is a full thickness continuous suture that allows for the mucosa to be inverted into the lumen of bowel anastomosis. The suture is started at the edge of the anastomosis and brought full thickness from inside to out on one side, then outside to in on opposite side. This is cornal suture. So Cushing, what is this Cushing? It is same like cornal suture, but this time we will not enter the lumen full thickness. We only go submucosally. So cornal and Cushing are same. Cornal and Cushing are more or less same. Cornal we do full thickness. Cushing we do only submucosal. We don't go into the lumen. Same way, outside in, inside out. But when I'm taking in a Cushing, I take it only at the level of submucosa. I don't go full layer. Whereas when I take cornal, I will go full thickness. Okay, that is the difference between Cushing and cornal. So the question is on Gamby suture. What is Gamby suture? It is an interrupted single layer suture that inverts the mucosa into the lumen. So how I take Gamby suture? Please see the picture. This most of you would have done this Gamby suture. We go full thickness first. Then when I'm going to come out of the bowel, I will go through submucosa. Submucosa again on the opposite side. So go full thickness, come out at the level of submucosa. This will prevent the everting of the mucosa. This is called as Gamby. So it's a single layer interrupted suture that inverts the mucosa into the lumen. Suture is brought full thickness, then passed back through the mucosa to exit through the submucosal layer of the same side. It is then passed through submucosa through the mucosa of the. See, it's simple. We have to go like this. Go inside, come out through the submucosa, then go like this. Otherwise, what we usually do, we do like this. That will cause mucosal protrusion. So to prevent that, they come out at the level of submucosa. That is answer called as Gamby suture. So finally, there is a gold standard suturing. What we do as a gastrosurgeons is double layer closure, in which this technique of Zerny-Lambert is, this technique features an inner full thickness continuous absorbable suture surrounded by an outer layer of interrupted, often permanent seromuscular Lambert. That is called as Zerny-Lambert. So let us come to the choices. Gamby suture is a continuous suture. True or false? Yes, it is a continuous suture. True. Cornal suture is a full thickness continuous suture. True. Halstead suture is a horizontal mattress seromuscular suture. True. Lambert is seromuscular, both intermittent or continuous. Both intermittent or continuous is Lambert suture. So in this, if you see, Gamby is not a continuous suture. It is an interrupted single layer suture that inverts the mucosa. So the answer here is therefore A. It is not a continuous suture. It is a false statement. It is a Gamby inverting the mucosa. The main aim is to inverting the mucosa. It is an interrupted suture in which the suture needle travels via submucosa. Don't forget this Gamby. So though we are not using practically, these sutures are asked in the exam. So the commonly used suture by us in gastrosurgery as well as by you in general surgery is either is Lambert suture, one. We don't use Cushing suture and all, we never use. We use cornal suture, yes. Halstead suture I have never used in my practice. So Gamby is a suture which is going to be asked in the exam, highly expected, because this picture is there in image-based question. Therefore, please remember all these images are from Shackelford. All the images can come as such. So don't forget these images. Calcium absorption, false statement. So this is again a general surgery question or SG question, we don't know, but it is there from Shackelford. Calcium absorption happens in duodenum, no doubt in that. It is mediated by acid, parathyroid hormone, vitamin D. It is absorbed along with the B12 in terminal ileum. Movement of out of the cell to circulation is by means of facilitated division. It is not absorbed in terminal ileum. It is absorbed in jejunum and duodenum only. Okay. The main hormone needed for the absorption is vitamin D and 20, which is getting converted to 25-hydroxy to 125, which is active form of vitamin D. This increases the availability of calcium binding protein. So 125-dihydroxy cholecalciferol increases the availability of calcium binding protein, and it is helping absorption by specific protein. Okay, calcium ions move out of the cell into the circulation by means of facilitated diffusion. So it is absorbed into the cell by protein. If this is a cell, by a protein, it is absorbed into the cell from the lumen. From the lumen, it is absorbed from the like this, and from here it is moved into the blood circulation by a facilitated diffusion. So it is there from Shackelford. So this question is there in Shackelford. So probably this is also a Shackelford based SGA question. Please remember this question. So this is again a classical question from Sabiston. Repeatedly, we ask you to read this table. So this table contains enormous MCQ points. So Cullen sign, we know it is periumbilical bruising. Great Turner sign, you know, flank bruising and pancreatitis. Ransohoff sign is a yellow discoloration of umbilicus due to rupture of bile duct. So Cruvelier sign is a varicose veins at the umbilicus in portal hypertension. There are so many other signs in this table. So please go through this table with the signs. Aron sign, okay, pain in the epigastrium with the pain or pressure in the epigastrium or anterior chest with a persistent firm pressure to the McBurney's point. When I keep pressing the McBurney's point, we will have a pain in the epigastric region. Aron sign between abdominal wall and iliacus. Bloomberg sign, you know very well, rebound tenderness. Carnot sign, loss of tenderness when the abdominal wall muscle is contracted. This helps you to know there is an intra-abdominal bleeding. Chandelier's sign is a gynec disease, pelvic disease having a pain. So like that, all the points are there. Please go through this. Tin-horn sign and all is no more done. It is a pain by gentle traction of the testis in appendicitis. Rosing sign is a pain in the right side when I press the left side of the abdomen. So all these signs are very important. The question is asking, Cullen sign, umbilicus true. Great Turner sign is not umbilicus. It is lumbar region. Ransohoff is umbilicus, yellow pigmentation. Cruvelier is varicose veins in the umbilicus. So please don't forget which is not true in this point. So this may be a general surgery questions also. So remember these questions. So this is again a favorite SG question related to glucagon-like peptide 1 and glucagon-like peptide 2. Both are secreted by duodenum and jejunum by means of L cells. So these are elevated, not down-regulated. They are increased. They are increased in jejunal. When I do a jejunal resection, GLP-1 and GLP-2 are increased. So therefore, they found out by increasing GLP-1 and GLP-2, there is a enterotropic factor. Enterotropic means small bowel grows because of this. Therefore, teduglutide is GLP-2 analog has increased, has been used for this short bowel syndrome. So they found out when we are using GLP-2 analog, it is enterotropic. No, there is therefore a concern of increased malignancy. Always therefore do colonoscopy before this procedure. And teduglutide is associated with decreasing the parenteral nutrition. So when you start teduglutide, gradually if you are giving 1 TPN per day, you can give 1 TPN for 2 days once. Like that it can reduce. So what is wrong here is down regulation is seen as wrong. So let us see about this disease. Novel drug therapy for short bowel syndrome includes teduglutide for parenteral nutrition dependent patients. Is a recombinant human analog of glucagon-like peptide 2. It is a GLP-2 analog. Both GLP-1 and GLP-2 are tropic hormones released from, this point is little mistake here. It is also wrong. A is also wrong. It is not secreted by duodenum and jejunum. It is from ileum and colon. This is what we see is secreted by ileum and colon. So both GLP-1 and GLP-2 are intestinal tropic hormones secreted by endocrine cells in ileum and colon. Don't forget this point. It is not from jejunum. It is of GLP-1 and GLP-2 synthesis is seen after ileal resection if there is remaining colon in a jejunocolic configuration. So if I have removed the ileum, the remaining colon will upregulate GLP-1 and GLP-2. These GLP hormones promote height of the villi and crypt cell mass increase. So teduglutide associated with the parenteral nutrition volume reduction also led to improved quality of life scores among the short bowel syndrome patients. The increased crypt cell mass caused by teduglutide raised the concern of promotion of neoplastic growth, and therefore a prospective colonoscopy must be better to exclude already any active malignancy. For example, if there is a small malignancy in the colon, if I start teduglutide, it will proliferate the tumor. Therefore, teduglutide, when you start, always do a colonoscopy. That is a very important point from Shackelford. Please don't forget GLP-1 and GLP-2 related points. It is secreted by ileum and colon. So the answer here wrong are A and B. Okay. So this is a simple anatomy related question. I think you would have answered simply without any difficulty. Pericolic vein is nothing but marginal vein. All the bowel will be supplied by pericolic vein, no doubt. And splenic flexure is supplied by left branch of middle colic vein and left colic vein. So this is a classical point. That is correct. Transverse colon can be supplied by ascending branch of left colic vein, middle colic vein, and right colic vein. Ileocolic vein is supplying only the cecum and ascending colon. It is not related to transverse colon. So ascending branch of left colic vein is wrong. Sigmoid colon is supplied by sigmoid vein, superior rectal vein, inferior mesenteric vein. That is correct. Hepatic flexure. This hepatic flexure is supplied by middle colic vein, right branch, right colic vein, yes. Ileocolic vein, again, it is wrong. Ileocolic vein is not going to supply up to the hepatic flexure. So the B and D are not correct answers. So left colic vein is not going, sorry, B is correct. Ascending branch of left colic vein, this is the ascending branch of left colic vein. That is correct. So hepatic flexure not supplied by related to the veins. So the answer here is D. D is answer. So you can just understand based on the veins, they're asking a question. So no confusion in that. Since this is also a favorite topic, I have made this question. There are two important collaterals in the colon. One is marginal artery of Drummond. All of you know what is it? It is a marginal artery of Drummond is seen all along the vessel like this. This is one collateral. Number two collateral is arc of Riolan. So arc of Riolan is seen. This is a picture showing you arc of Riolan, which is a communicating artery between left and right at this level. So this is an arc of Riolan. It is a connection between ascending branch of left colic artery and left branch of middle colic artery. So this is arc of Riolan, also called as meandering artery. So meandering mesenteric artery and the left colic artery. The meandering mesenteric artery is generally appreciated when there is a critical stenosis or occlusion of SMA or IMA. So therefore, you have to look for this arc of Riolan, whether it is prominent or not. So if it is very prominent, MMA during left colon surgery, if I ligate, may result in catastrophic ischemia. The location dependent upon the direction of flow. For example, if the flow is antegrade, SMA, IMA, SMA, IMA, ischemia of the sigmoid colon can happen, and ischemia of the right colon and majority of small bowel. So if you see a prominent arc of Riolan, don't cut it. Prominent arc of Riolan is a finding to say there is an obstruction of either SMA or IMA. IMA occlusion can be identified from the prominent artery arc of Riolan. So whenever you see a prominent Riolan, you should be very careful. There is some obstruction, either it is an SMA obstruction or IMA obstruction. You should not ligate. You can land up in huge trouble of bowel gangrene. This is a very important point from arc of Riolan. So just remember, related to venous drainage. So we had around 8 questions from small bowel, and we had some 5 to 6 questions from colorectal. So they have equally distributed the questions as per SG exam. So let us see the other questions from colon. So this is again a simple, straightforward question, not so complicated question. It's like a basic general surgery question. Not true about extraintestinal of inflammatory bowel disease. So please remember, this question is the most common in Crohn's disease than ulcerative colitis. That is 100% true. Can you tell me what is the most common extraintestinal manifest? It is arthritis. It is arthritis. This is what Sabiston says. Better to read this topic from Sabiston. So no risk of colonic malignancy after liver transplant in PSC cases is absolutely wrong. Even if you do liver transplant for primary sclerosing cholangitis patients, they still have the risk of colonic malignancy in ulcerative colitis cases. So PSC is seen in 5% of IBD. Yes, PSC cases have IBD diagnosed. PSC cases will be having inflammatory bowel disease diagnosed 8 to 10 years before in majority of the cases. That is also true. So let us see. There is a high prevalence of extraintestinal manifestation in patients with Crohn's, and arthritis is the most common. One of the most common manifestation is also sacroiliitis and ankylosing spondylitis. All these are various bone manifestations seen. Similarly, skin manifestation. In skin manifestation, when you combine together, pyoderma gangrenosum is more frequent than erythema nodosum. Erythema nodosum is a painful nodule, whereas pyoderma gangrenosum is an ulcer. Pyoderma gangrenosum is an ulcer, painful ulcer. You should not debride. For both the cases, only steroids. Steroids are enough. especially for pyoderma gangrenosum. You can even give topical steroids. Don't do any procedure on pyoderma gangrenosum. If you debride, it will grow further. That is called as what phenomenon? Pathology. More growth of the pyoderma gangrenosum is called as pathology on trauma. Okay, you should not do anything on that. So manifestations include uveitis, iris of the patients, and is independent of IBD. At its worst, it can progress to cirrhosis, liver failure, and can cause need to transplant. So, patients with sclerosing cholangitis are higher risk of colorectal cancer and are also at higher risk of development of pouchitis. So when you have a PSC with a IBD, more risk of colon cancer is also there, and very clearly given in Sabiston. PSC patients with a colonic ulcerative colitis have increased risk of colorectal dysplasia and neoplasia even after orthotopic liver transplant for PSC patients following orthotopic liver transplant, because we have to give lifelong immunosuppression in these patients. Thus, in PSC patients who undergo liver transplant, annual colonoscopy should be continued. It should be continued. So when you see a patient with PSC, in most of the cases, in 80% of the patients, you have diagnosed ulcerative colitis prior itself. 80% of the time, would have diagnosed ulcerative colitis some 8 to 10 years back. Okay, don't forget this question. Below is the picture of, see, another image-based question every year they ask is low anterior section or anterior section related images from the pelvic area. So this time they asked about the hypogastric nerve. They asked about left and right hypogastric nerve. They asked question on left hypogastric or right hypogastric. Something have pointed out and asked. They didn't give this. They didn't give this. Structure shown here is having following function. That is the point. So they pointed out anterior section image and they pointed what is the function of that nerve. So this nerve is having what function? Hypogastric nerve. This is discussed in our module. So you can see in our INI SS module, I have discussed about this concept very detailed from Sabiston. So this is a nerve. You have to remember there are two plexus. This is presacral plexus. Presacral plexus. This is lateral plexus, also called as pelvic plexus. Presacral plexus and pelvic plexus. Presacral plexus is containing hypogastric nerve. Is giving hypogastric nerve. So from the presacral plexus only, you can see there are left and right hypogastric nerves coming down. So this presacral plexus contains only sympathetic fibers. Please don't forget. Only sympathetic fibers. Whereas pelvic plexus contains sympathetic plus parasympathetic. So sympathetic plus parasympathetic is seen in pelvic plexus. Therefore, when you are doing a cancer operation, when you go laterally and damage the pelvic plexus, you cause bladder plexus, lateral pelvic plexus. You can land up in and atonic bladder. Whereas sympathetic plexus injury is nothing big to worry because there will be only retrograde ejaculation and mild bladder dysfunction. Whereas atonic bladder is seen in pelvic plexus injury. So presacral plexus contains only sympathetic fibers. So the nerve which is carrying this is only sympathetic fibers. This is only carrying sympathetic fibers. The answer is A. Sympathetic fibers. So when you are going to damage a hypogastric nerve, the patient can get retrograde ejaculation and bladder dysfunction. But at the same time, when you damage this pelvic splanchnic nerves, patient is going to suffer too much. That is going to be a classical injury called as atonicity and impotence. I have seen patients who comes to us because of the erectile problem after the injury of lateral pelvic plexus. So this is again a simple NEET SS level question. Adenoma-carcinoma sequence of Fieron-Vogelstein. This is also discussed in our regular NEET SS also. Fieron-Vogelstein sequence, adenoma-carcinoma sequence. It starts from normal epithelium, dysplasia, adenoma, intermediate adenoma, late adenoma, etc. It goes on. In this, the first hit is by APC. Accelerated initiation is by APC. Accelerated progression is by mismatch repair gene called as. So the second step is HNPCC. So first step is FAP. Second step is HNPCC. Initiation is not by HNPCC, and the last hit is P53. So APC, the order you should not forget. This is usually asked in exam. APC, HNPCC, which includes mismatch repair gene, followed by KRAS, followed by DCC, and finally P53. This order is called as adenoma-carcinoma sequence gene order. Okay, this adenoma-carcinoma sequence gene order, don't forget APC, HNPCC, KRAS, DCC, P53. That is a classical order. So initially you have initiation, tumor initiation is by means of APC gene. So in initiation, it is normal, HNPCC is normal. In progression, which is accelerated, HNPCC is accelerated. So that is a question from this flowchart. This is a question from this flowchart. Okay. Acceleration of progression is by HNPCC. Acceleration of initiation is by APC. Okay, just remember this question. This is a new question. Which class of monoclonal antibody is ipilimumab? The problem in INI SS exams is, since the AIMS examiners commonly follow up the patients for chemotherapy and other immunotherapy, they ask the latest immunotherapy regimen. Some drugs they will be asked. Definitely one question will come on latest drug, which is very difficult for us to even find out in many textbooks. So one such drug asked this time is ipilimumab, which may be a NEET SS, general part question or gastro part question. Which class of monoclonal antibody is ipilimumab? It is CTLA4. So blockage of co-inhibitory molecules such as CTLA4 and program death 1, PDL1, 22, 21 and 20, PDL1, this is not 21, 22, this is a reference. See, it's just reference. So CTL1, LA4 and PD1 and PDL1 can yield dramatic and durable tumor regressions in several types of solid tumors. So CTLA4, through its engagements with the ligand CD80 and 86, attenuates activation and expansion of antigen T cells, and it can be thought as one breaking mechanism of the immune system. So CTLA4 breaks the immune system. Therefore, if you give a monoclonal antibody that blocks CTLA4, that is a drug which is found now called as ipilimumab and tremelimumab. Limumab. So ipilimumab, tremelimumab. So they both are used now as CTLA4 blockade. It is used as CTLA4 blockade. It is used in many cancers, especially melanoma patients. And second co-inhibitory receptor is on T cells is PD1, program death 1, which is engaged by its ligands PDL1 and PDL2. PDL1 and lesser extent PDL2 are expressed by a broad range of tumors, melanoma, lung cancer, colon, breast, ovarian, pancreatic, hematological. Therefore, FDA approved PD1, PDL1 inhibitors for many cancers. You can see a lot of cancers, including colorectal cancer, hepatocellular cancer, all places you can use this. So now, which is best used for these type of metastatic melanoma is combined program death 1, CTLA4. So carry home point is, please don't forget CTLA4 is ipilimumab. Okay, ipilimumab. Don't forget this drug is a high yield MCQ topic for your exam. So highly expected, again, ipilimumab can again come for your exam, CTLA4. So please go through all the monoclonal antibodies. Definitely you might get 1 or 2 antibodies in the exam. So this question is actually a repeat question. To be frank, I told you we will not get a repeat question, no, but this question is asked 3-4 years back related to probiotics and prebiotics. Probiotics contain live cultures of bacteria and yeast. Live cultures of bacteria and yeast. Xylem are non-digestive fibers used as a bulk-forming laxatives. That is also true. Prebiotics are non-digestible oligosaccharides that stimulate good intestinal flora. Probiotics are used in primary prevention. No, it is wrong. Same choice has come before. Probiotics are used in primary prevention of Clostridium. Please don't forget, it is wrong. Probiotics can be defined as dietary supplements that contains live culture of lactobacillus and bifidobacterium. So they have a widespread health benefits, including immune function, anti-inflammatory, suppression of enteropathogenic colonization. In addition, they increase the digestibility of proteins and enhance the absorption of amino acids. So probiotics can increase amino acid absorption. Please don't forget this. Protein absorption is increased. Probiotics have been shown to prevent Clostridium difficult diarrhea, but there is primary prevention we cannot recommend it. There is no such evidence available. So indications of probiotics are evolving. So currently there are so many indications, including colorectal conditions like necrotizing enterocolitis, ulcerative colitis, pouchitis, constipation. All these places we can use probiotics. What is prebiotic? Prebiotics are nutrients that support the growth of probiotic bacteria. Prebiotic supports the growth of probiotic bacteria. So prebiotics are nothing but non-digestible oligosaccharides like inulin that help the host by stimulating growth of certain beneficial bacteria. So good bacteria growth is promoted by prebiotics. Prebiotics are nothing but inulin. There is a growing data to suggest health benefits. However, there is little evidence to guide recommendations for the regular use. The main source of bacteria is dietary fiber composed of starches and non-starch polysaccharide. However, not all complex carbohydrates are fermented in the manner. Dietary recommendations of adding fiber generally refer to bulking agents such as lignin and psyllium, which are non-absorbable, non-fermentable by the colonic bacteria. Bulking agents decreases the colonic pressure, decreases colonic transit time, and help in constipation patients and prevents colonic diverticulum. Okay. So short chain fatty acids is a favorite topic of AIIMS examiners. Most commonly available short chain fatty acid is acetate. Acetate is the most commonly seen. Butyrate is a primary source of nutrition for colonocytes butyrate. Because mammalian cells do not produce butyrate, colonic epithelium and luminal bacteria form an essential symbiotic relationship. So antibiotics disrupt this cohabitation. Decreased bacteria leads to less butyrate, which in turn negatively affects colonocyte function, leading to diarrhea. This is one important point. So when you give antibiotics, this butyrate is less, and that may be diarrhea. So likewise, mucosal atrophy can also cause similar diversion, colitis. So the role of short chain fatty acid extends beyond the colon. Besides butyrates, two other short chain fatty acids are produced or absorbed. Hepatocytes metabolize short chain fatty acids for use in gluconeogenesis, and muscle cells oxidate acetate to generate energy. Additionally, acetate is the primary substrate for cholesterol synthesis. Acetate is found to be a cause of cholesterol synthesis. Therefore, people thought when we prevent acetate absorption, we can prevent cholesterol, we can reduce cholesterol level. The benefit of acetate, production of acetate is reduced by this psyllium, which in turn has a beneficial effect on cholesterol. So the production of acetate is reduced by giving psyllium, which benefits in reduction of cholesterol level. Similarly, propionate, which has glycolytic role in the liver, may also lower serum lipid by inhibiting cholesterol synthesis. Okay, so don't forget, these are some points from book Shackelford. And short chain fatty acids are the one causes of carbon dioxide, methane, and hydrogen. That is the cause of 50% of the flood test is because of these short chain fatty acid fermentation. The end products of short chain fatty acids are carbon dioxide, methane, and hydrogen. So this is about the gastro. We had around 20 to 25 questions from this part alone, from GI luminal alone. So we have 2 questions from hepatobiliary also. General surgery questions I will discuss based with the help of other faculties soon. Today we will have GIT and HPP. So any doubts from the questions what we had? Shall we start with Santosh Anand sir? Sir is waiting, huh? Yes, sir is available. Yes, sir. Sir, welcome, sir. Dr. Santosh Anand sir.
Hello, sir. I've joined.
Sir, how is the paper, sir? HBP paper.
It was partially difficult.
Any brief outline about the paper?
Few questions were a bit difficult.
One. Okay.
Few questions were a bit difficult, and few questions actually they had taken from the previous edition of Bloomgut rather than 7th edition, as it usually comes from
Bloomgut. Okay. Okay,
sir. Question bank. Probably they would have taken from the previous question banks. I was not able to find answers for a few questions from 7th edition Bloomgut, but I was able to find it from the 6th edition of Bloomgut, sir.
Okay.
And 1 or 2 questions were from Indian papers.
Okay, sir.
Indian other papers.
Okay, sir. Your internet is okay, na, sir? Your internet is okay, na?
Yes,
we are getting stuck up when you're taking class. It is getting stuck up. Is it fine?
Just a minute.
Vinod, is it fine now?
Just a minute.
It's fine, sir.
Yeah, I'm feeling Sar's voice is getting stuck up. So friends, stay tuned. Sar is coming up for HBP questions. Dr. Santosh and Sir will be discussing HBP questions. Just a few minutes. We'll be back. Yes, as you all see, INI SS paper is classical paper. You should go through that paper. Yes, sir.
I brought an alternate also, sir. So
please go through the. Shall you? You can share your screen, sir, and you can start.
Yes, sir.
So I will be watching in live tube, sir. YouTube.
Okay.
You can just start the class.
So I will start.
Yeah, we will be sharing both the PDF in our group. Don't worry. Our SG group will be sharing. I hope most of you are there in the WhatsApp SG group. I will be sharing all the PDF, both SARS and mine, in the PDF of our WhatsApp group. Okay. Thank you. Thank you, sir. You please start the session.
Sure, sir. Sure. I'm just starting to share it. So is it visible?
Yes,
yeah,
sir.
I think my screen is visible. Shall I proceed?
Yes, sir. Please.
Okay. So I think luminal GI questions were covered by Dr. Raj Mahendran sir. So I'll be covering HVB questions. So this question paper was a mixture of easy and slightly difficult one. As I was discussing with sir, few questions were taken from the previous edition of Bloomgart, 6th edition. We can find answers from the 6th edition rather than 7th edition. So we'll go subsection wise. First, liver. The patency of a leno-renal shunt or the spleno-renal shunt is assessed by all except. So the options given were CT photography. What is CT photography? So it is given at an excess dose of contrast, and time is certainly slightly different. Endoscopic ultrasound, disappearance of varices on apogee endoscopy, and Doppler of splenorenal axis. The answer is EUS because we don't do EUS for portal hypertension. CT photography will give us an anatomic view of the splenorenal shunt, whether the contrast is flowing through that or not. Disappearance of varices on endoscopy is an telltale evidence that the portal hypertension has come down because of shunt, and Doppler of splenorenal axis again can show us the dynamic flow of blood from the splenic vein to the left renal vein. So now what Bloomgart says is the shunt patency should be assessed in most of the patients before discharge. This can be done with an ultrasound, by which they mean it's a Doppler. But the other ways of doing is shunt catheterization. Initially, they used to do intraoperatively, but post-operatively, if we want to catheterize and check, what we can do is we can puncture the portal vein branch through the liver and then measure the pressure difference, one in the portal vein, the other through the shunt. If it is patent, we can cross and then measure from the renal vein side also. So moving on to next question, Barcelona Clinic liver cancer staging system for hepatocellular carcinoma includes all of the following except. So the options given were child Turgot-Puck score, model of end-stage liver disease, performance status, and tumor extension. This is simply a straightforward question. The answer is MELD score is not included in it. So it takes into consideration three things. One is status of tumor. Second is status of the liver. Third is the performance status. So just remember three statuses. So this includes based on tumor burden, liver function test, and physical status. So it doesn't include a MELD score. Okay. So in simple, HCC is classified according to BCLC as very early stage, early, intermediate, advanced, and terminal stage. Very early stage is single less than 2 centimeter with a very good preserved liver function. Early stage is single or less than 3 nodules, which is each less than 3 centimeters with a very good liver function and preserved performance status and liver function. So these two stages are essentially amenable for resection or transplantation based upon the status of liver. If the status of liver is good, go for resection. If the status of liver is not good, then go for transplantation. Now, if there are few contraindications for liver transplantation, depending upon the age, but still they fall under early stage, then we can go in for ablation. Okay. Intermediate stage, when the nodules are more than this, liver function is still preserved with a very good performance status, then going for TACE. Now, extended liver transplantation criteria. This is not BCLC criteria. This will fall under some other criteria like Japanese criteria, UCLF criteria are there. According to the size and AFP, they can be subjected to transplantation. They can be downstaged with TACE and then be subjected to transplantation again. But if it is an extensive bilobar involvement, then systemic treatment. There are lots of new systemic treatments which have come, but terminal stage, only 3 months is the life expectancy, so we don't subject them for any form of treatment. Okay. So ablation, resection, transplantation, and TACE are the core management of local and loco-regional HCC. So these are the other staging systems used for hepatocellular carcinomas. We have Okuda, CLIP, QP, BCLC, which are very commonly known. So everything has tumor morphology, but BCLC has, in addition, performance status, and Okuda, CLIP do not involve the performance status. Okay. What is the cutoff for portal hypertension? And sorry, this is portal venous hepatic venous pressure gradient, HVPG. So the answer can be both. At one page, page number 83, Bloomgart 7th edition says that HVPG greater than 12 millimeters of mercury has classically been defined as portal hypertension because beyond this only the varices will bleed. Less than 10, the formation of varices and liver decompensation doesn't occur. But at the same time, that another figure in Bloomgart's same 7th edition has classified a portal pressure or HVPG from 5 millimeters of mercury to more than 20 millimeters of mercury. And they have said anything beyond 5 millimeters of mercury is considered as mild portal hypertension. Now, if we go and see other books also, and previous edition of Bloomgart also, portal hypertension of HVPG greater than 5 is considered as mild. So the answer should be 5 here and not 12. Now, is there any importance of other values? Yes, there are importance of other values. If it is a compensated cirrhosis, when HVPG goes beyond 10, it says or predicts certain things like development of gastroesophageal varices. First, clinical decompensation can occur in patient without varices. Patients are more prone to develop HCC. And if the patient with HCC has a HVPG of 10, they are more likely to undergo decompensation after they are subjected for surgery for hepatocellular carcinomas. Beyond 10, varices start bleeding. Beyond 12, 10 varices is formed, 12 varices start bleeding, and 16, first clinical decompensation in patients with varices and the increased risk of mortality. Now we go for decompensated cirrhosis. HVPG 16, chance of variceal rebleeding and mortality is high. This is a very common question. Like HVPG of 20 and above, if it is the first one, it's very likely that the endoscopic control of acute bleed is very difficult. Endoscopic failure rates are very high if HVPG is 20 and above, so they should be subjected to TIPS or surgical decompression. 22 and above, in alcoholic cirrhosis, patients' mortality is very high and they tend to develop alcoholic hepatitis mortality also. Beyond 30, they tend to develop spontaneous bacterial peritonitis. Now, the next question was an image-based question. So, a cross-sectional image of the cephalomost portion of liver was given like this. So, I have marked 4 veins in it, and the question was, which section or which segment of liver is not seen in this picture of CT? So which segment is not visible? 8, 7, 2, and 3. I'll go back to the image again. So cephalad or the superior most portions. To the right of right hepatic vein, there will be 7. Between right and middle hepatic vein will be 8. Between middle and left hepatic vein will be 4A. And between left hepatic vein and left border will be 2. 3 actually comes below. Okay. So the answer is 3. 3 is not visible. So that's the explanation of what I gave you. And if we come down, we start seeing segment 3, segment 4B, segment 5, and segment 6. Okay. So cephalad portion, we will not be able to see segment 3. Now, minimal hepatic encephalopathy after a non-selective shunt is seen in. So, after shunt, particularly non-selective shunt like mesocaval shunt or proximal splenorenal shunt, the blood flow from the systemic circulation is turned into the portal circulation is turned into the systemic circulation without going into the liver. So the toxins can easily enter, or the metabolites can easily enter into the systemic circulation without getting filtered by the liver. So the level is very high, very high in cirrhosis, seldom seen in EHPU and Budd-Chiari syndrome, but minimal hepatic encephalopathy can occur in non-cirrhotic portal hypertension. So the answer for this we got from an Indian paper. AIMS paper, the higher incidence of encephalopathy has been reported following shunt surgeries in this NCPF patients. Less than 2% was for EHPU patients and more than 13% was seen in cirrhotic patients. Cirrhotic patients, encephalopathy post non-specific shunts can go as high as 60 to 80% also. Now the next question is HCC tumor, and this is based on BCLC. So very good performance status, ECOG score of 0. Single liver tumor which is 3 centimeter in size, no metastasis, and most importantly, patient doesn't have cirrhosis. What is the best treatment? So the answer for this is resection. This comes from the Mazzaferro et al. The Mazzaferro et al. Says that if the liver function is good without cirrhosis, tumors should be subjected for resection first and not for transplantation. So tears and tear are only for intermediate stage. Transplant and resection can be given for early stage. When the liver performance status is, liver status is very good without cirrhosis, then resection is preferred over transplantation. So Bloomgart 7th edition says that multiple chapters like liver resection is a treatment of choice for localized HCC in the absence of cirrhosis. So the next question is shunt which is not used in EHPVO. So the options were PSRS, distal splenorenal shunt, Inaguchi shunt, and Mitra shunt. Again, the answer for this comes from an Indian paper. DSRS is the distal splenorenal shunt. It's a selective shunt, and it is particularly used for cirrhotic patients, though the action is temporary in cirrhotic patients. This will prevent, it's a selective shunt, and it will prevent development of hepatic decompensation or hepatic encephalopathy in patients having cirrhosis. Now, why PSRS is the most commonly done shunt for EHPVO is it removes spleen also. EHPVO patients are usually young in their first or second decade of life. Because of the sheer size of spleen, they will have a wasting, failure to gain weight, all those things. But removal of spleen will restore back all those things. Inaguchi shunt is again shunt between the left renal vein and the IVC. So again, the answer for this comes from the same paper. The distal linorenal shunt, though preferred in patients with cirrhosis, doesn't offer advantage in EHPVO, as encephalopathy doesn't occur even after non-selective photosystemic shunts in these patients. So EHPVO patients, you do a non-selective shunt, they don't tend to develop hepatic encephalopathy because some amount of blood which can go through the liver is sufficient enough to filter all those toxins or metabolites and prevent the development of hepatic encephalopathy. So what is Mitra shunt? Mitra shunt is side-to-side splenorenal shunt. In proximal splenorenal shunt, what we do, we divide the splenic vein and then anastomose splenic vein to the left renal vein. Whereas in this, we retain the spleen, we don't divide it, but do a side-to-side splenorenal shunt. That is Mitra shunt. So which condition HCC develops without cirrhosis? The options were fibrolamellar HCC, hepatitis B virus, non-alcoholic fatty liver disease and alcoholic. We definitely know that non-alcoholic fatty liver disease and alcoholic liver disease will require cirrhosis before development of HCC. But fibrolamellar and hepatitis B virus also can cause HCC without the development of cirrhosis. But if we compare these two, for example, if 100 patients of fibrolamellar HCC are there, almost nil patients will have cirrhosis. Whereas 100 patients of hepatitis B virus infected patients have HCC, almost 60 to 80% will have cirrhosis. So it's a relative answer. Absolute answer is fibrolamellar HCC. So young adults, average presentation is 25 years. Absence of cirrhosis or any risk for liver disease. And this comes from Bloomberg 7th edition, page number 8. So again, another was an image-based question. So I don't have the exact image, but I have taken image from Bloomberg and display. So two images are there. The left side image where the pointer is there shows a arterial face because aorta is enhanced, and we also see the branches of celiac artery enhanced. There is almost homogeneous or slightly heterogeneous enhancing lesion in the segment 4 of liver with a central scar. When it goes to the portal venous phase, the right image, the portal venous phase, because liver is nicely enhanced and we are able to see the portal vein very nicely. The lesion becomes almost isodense to the surrounding liver, but the central scar remains hypodense. So what hepatic lesion is this? CT image of a liver tumor with a central scar, HCC, FNH, hemangioma, and adenoma. So the answer is FNH. Now, there is another tumor which can also have a central scar, but this central scar has calcification. So this looks almost similar. So, and slightly more enhancing in the portal venous phase also. So, fibrolamellar HCC also has central scar, but 60 to 90% of them will have calcification. The enhancement pattern of fibrolamellar HCC is heterogeneous. In addition to these two findings, they will have lymph node enlargement and they can sometimes invade the nearby vessels, which are absent in FNH. So FNH will have a central scar, but without calcification, they will have homogeneous enhancement. They will not have lymph node or vascular invasion. Now, this is a repeat question. To which vein, anterior fissure vein, drains? This was asked a couple of years before also. So the options given were left hepatic vein, right hepatic vein, middle hepatic vein, and IVC. I'll take this as an IVC. And though the anterior fissure vein can drain into IVC, middle hepatic vein, and right hepatic vein, the most common, or nearly 70 to 80% of the time, the anterior fissure vein drains into the middle hepatic vein. Now the question is, what is this anterior fissure vein? So the anterior fissure vein can be classified into three types. The liver of a patient can be classified based upon the anterior fissure vein anatomy into three types. So type 1 is the most common, nearly 80% of one. 11 to 12% will have type 2, and remaining approximately 10% will have type 3. Now, type 1 will have a single anterior fissural vein. Type 2 will have multiple anterior fissural vein. Type 3 won't have an anterior fissural vein. Now, in type 1, it is classified into type 1A and type 1B, depending on where the anterior fissural vein is draining. So, majority of them, nearly 70% of type 1 or 90% of type 1 anatomy will drain into the middle hepatic vein. Only a small portion will be draining into the right hepatic vein. Even in type 2, majority of them will be draining into multiple anterior fissural veins will be draining into the middle hepatic vein. Again, a good amount of patients with multiple anterior fissural vein can drain into both right and the middle hepatic vein. So if we consider those numbers, 70 plus 2%, 72% will be draining into the middle hepatic vein. Now, what is the importance of this anterior fissural vein? As it is shown in this picture, the anterior fissural vein drains exactly or traverses exactly between the two branches of segment 8 portal vein. So the dark black branch of the segment 8 portal vein supplies the dorsal portion of segment 8. The gray, light gray branch of segment 8 portal vein supplies the ventral portion of segment 8. So if you want to do subsegmentectomy of segment 8, this anterior fissural vein can act as one of the important landmarks, particularly if it is single. And this anatomy we will get in nearly 70% of the people. So that brings to the end of liver questions. We'll move on to the biliary questions. Biliary questions were relatively easy. So good amount of questions from both gallbladder and CBD were asked. Moving on to questions. What's the risk factor of GB malignancy in a patient on follow-up for GB polyp? So the options given were polyp less than 1 centimeter, multiple subcentimetric stones, porcelain gallbladder, and asymptomatic. The answer is porcelain gallbladder. See, the risk of malignancy in porcelain gallbladder, which was claimed 2-3 decades back, was very, very high, nearly 60-65%. Now, the claimed risk has actually come down, but the risk of GB malignancy in porcelain gallbladder has never become zero. Okay. So, Bloomberg 7th edition, page number 257, says that older studies 10 to 20% of the patients develop gallbladder carcinoma, but recent reports indicate the risk is 10%. If we go to 6th edition or 5th edition, it can claim up to 60%. More importantly, any calcification in gallbladder wall is called as porcelain gallbladder. It is related to the type of calcification. Lower risk in complete calcification compared to selective calcification, otherwise called as stippled calcification. Any calcification on the wall of gallbladder is called as porcelain gallbladder. Stippled or selective calcification increases the risk of carcinoma gallbladder rather than a complete uniform calcification of gallbladder wall. Now, this was a question from pathophysiology of biliary obstruction, which is true among the following regarding the biliary obstruction. This question was taken from 6th edition of Bloomberg. So it says bile duct pressure greater than 20 centimeters of water causes septic complications. Cholesterol and phospholipids, but not the bile acids, affect cytochrome P450 and increases the apoptosis of the liver cells or hepatocytes. Bilirubin causes only microvascular but not macrovascular complications. Lithostatic bile increases after biliary decompression due to increase in bile salts. So last three were wrong. First one was correct. So 6th edition says with the relief of biliary obstruction, coming on to the last option. First two options, like when the pressure goes to greater than 20, there starts some reflex of the secretions from the bile duct back into the hepatocytes. So the bacteria which are present in the bile can easily enter into the systemic circulation. So cholangitis sepsis is common in patients who have bile duct pressure more than 20 centimeters of water. Now, we all know there is a terminology called as biliary atrophy, particularly in patients who have segmental atrophy following blockage of bile duct of that segment alone. That happens because of bile acids, because bile acids and the bile salts will stimulate or affect the cytochrome P450, not the cholesterol or phospholipids. They are not capable of stimulating cytochrome P450. So cytochrome P450 induced apoptosis is caused by bile acids and not by cholesterol and phospholipids. Bilirubin causes both macrovascular and microvascular complications. Lithostatic bile. See, we all know that particularly when we decompress using ERCP stent, when we put a small plastic stent, these tend to get clogged easily when compared to that of placing a stent in a non-obstructed patient. This is because cholesterol and phospholipids, the production of cholesterol and phospholipids resume earlier once the obstruction is relieved. The bile salts and bile acid formation happens slightly late. So when cholesterol and phospholipids are more, it is a more of a lithostatic bile and that happens due to a relative decrease in the bile salt. Okay. With relief of biliary obstruction, the normalization of biliary pressure, recovery of cholesterol and phospholipid secretion is more rapid than bile acid secretion. Therefore, bile becomes more lithogenic in this setting. This is the reason why there is premature occlusion of decompressive biliary stents placed for management of obstructive jaundice. So next is a clinical scenario on post-op day 1 following laparoscopic cholecystectomy. You see 50 ml bile in the drain. What is the next step? I actually don't know what was the entire question was. We presume that the patient is not septic, patient is not toxic, he doesn't have peritonitis. In this situation, one of the following which you will be doing. You will observe, you will explore immediately, you will do an ERCP and stent the defect, or you will place a percutaneous drain or a T-tube. Now, already drain is there. We presume that the patient is stable. Then we will observe only. Why? Because type A injuries are the most common injuries causing biliary leak following cholecystectomy. In this, the minor leak is from the minor duct, which is still in continuity with the CBD. Most commonly, they are from either cystic duct stump blowout or from a subvesical duct of Lushka. So 60% or 70% of these settle if we just observe. Okay. Now, when will you explore? We will explore if the patient is in peritonitis or there is no drain and he shows dehydration or signs of sepsis. ERCP and stenting only after MRCP if it shows a lateral injury or type A kind of injuries which are not settling, the amount is increasing. There is a doubt of slip down or a retained stone. Percutaneous drain placement can be done if there is a bilioma, but the patient is not having any sepsis or features of peritonitis. So again, practical question while operating. So on bile duct injury during lap coli, that is bile duct injury is identified intraoperatively. Which among the following is false? Sorry for the spelling mistake. Greater than 3 mm duct it should be reimplanted into the biliary system. If there is a injury to the main bile duct, if it is less than 1 centimeter, primary end-to-end anastomosis can be safely done. Less than 50% injury, which happens without cautery, it is only with scissors, then it can be repaired over T-tube coming out through the injured portion. T-tube comes out through the injured portion. Cautery injury requires resection and anastomosis. The answer is, see, if it is less than 50% injury, non-cautery injury, it can be safely repaired over T-tube, but the T-tube comes out through the different choledochotomy and not through the injured portion. So the others are true. Greater than 3 mm, if a duct is divided, we found the duct from the liver, it is more than 3 mm in size, it should be reimplanted. Less than 1 centimeter defect of CBD can be anastomosed over a T-tube or just like that. If the side injury, less than 50% of circumference is involved, less than 1 centimeter again. If it is a non-cautery injury, it can be repaired over T-tube, but the tube comes out through a separate choledochotomy. Any cautery injury, resection anastomosis is required. T-tube should come out of a separate choledochotomy. If the injury is even less than 1 centimeter but is closer to hilum, will require a bilioenteric anastomosis, which is either hepatico-jejunostomy or hepatico-duodenostomy. So this question was taken from the Subiston 22nd edition. These pages. This was not from Bloomberg. Next, case of malignancy of gallbladder. Lap coli was done. Specimen shows T1A, very early disease. What will you do next? You will observe, you will do extended hepatectomy, you will do segment 4B5 resection, or you will give an adjuvant chemoradiation. So T1A, simple cholecystectomy, if the cystic duct margin is not involved, if the bile was not spilled, then you can safely observe. The reason is why T1A and T1B are different. So T1A tumors, which do not go beyond lamina propria, okay, there is no submucosa. Lamina propria, again, muscularis comes. That's why T2, T1B itself is different when compared to other luminal malignancies. Okay. Simple cholecystectomy is curative in approximately 90% of the patients. Remaining 10% will have cystic duct margin positivity or bile spill. Re-resection is not necessary. The 1 year overall survival of 50% after simple cholecystectomy for patients with T1B tumors, whereas it is 100% for patients with T1A tumors. Okay. Approximately 10% of the patients have been reported to have residual disease after simple cholecystectomy for T1B tumors, and they are associated with 10 to 20% of recurrence, particularly to the lymph nodes leading to re-exploration. So T1B tumors, 10 to 20% there will be residual disease which can cause early recurrence to the lymph node. So T1B tumors essentially require completion radical cholecystectomy. If not done, only 50% will cross 1 year. Whereas simple cholecystectomy, whole cystic duct mass is not involved. There was no bile spill intraoperatively. 90% of them, this is suffice, and 100% of such patients will easily cross 1 year. Now, again, another image-based question for bile duct injury. I believe type B was given, but I have given a separate this thing. So what we see in this image is there is a side injury or a tangential injury to the common bile duct where cystic duct is joining. So this is type D. So depending upon the injury, Strasberg has classified bile duct injury, particularly post-laparoscopic cholecystectomy or post-cholecystectomy. So type A, as we discussed, it is leaking from the duct in continuity with CBD. It can be duct of Luschka or it can be cystic duct stump blowout. Type B and D, it is ligated, so they form strictures. Like type B, right posterior sectoral duct is ligated. Type C, right posterior sectoral duct, which was entering into the CBD low insertion, it is cut and bile will be actively leaking from both the ends. Type D, it's a tangential injury to the CBD. Now, type E is a classical injury where CBD is injured and CBD stricture is formed. So, E1, we have a common hepatic duct which is more than 2 centimeter intact. E2, we have a common hepatic duct less than 2 centimeters from the stricture. E3, again, only hilum is intact. We do not have common hepatic duct. E3, again, Sikora has classified into E3A and E3B. E3A, both roof and floor of hilum is intact. E3B, only the roof is intact. So till E3B, we can do hepaticojejunostomy with a single anastomosis. Whereas in E4, hilum is destroyed. So we'll require separate enterotomies for anastomosing right hepatic duct and left hepatic duct. E5 is again individual stricture formed for low inserting right posterior sectoral duct and also to the common hepatic duct. So again, this will require 2 anastomosis. So again, another image-based question. What we can see here is duodenum, Adenoma-carcinoma duct junction. There is main pancreatic duct. This is CBD. This is CHD. There is a dilatation of mid portion of CBD. There is no dilatation in the intrahepatic biliary radicals. So what kind of choleloccal cyst is this? This is 1B type of choleloccal cyst. We all know type 1, type 2, type 3, type 4, and type 5. Type 1 is involving the common bile or hepatic duct. Type 2 is a side outpouching from the common bile duct. Type 3 is choledococele, where ampullary portion of the common bile duct is only enlarged. Type 4A and type 4B. Type 4A, both intra and extra hepatic CBD is dilated. Type 4B, multiple extrahepatic is alone dilated. Type 5 is Caroli's disease, where we have both strictures and dilatation, string of bead appearance of intrahepatic biliary radicals. Now, type 1 is again classified into type 1A, B, and C, depending upon the type of dilatation of the common bile duct. So, type 1A, it's a cystic dilatation of the common bile duct. Usually, it doesn't extend into the intrapancreatic portion of the bile duct. Type 1B, only the middle portion or one of the segment of bile duct is involved by the choleloccal cyst. Type 1C is a fusiform dilatation. It starts from CHD and enters till the level where it joins with the pancreatic duct. So type D is also mentioned in the recent Bloomgart 7th edition, where there will be a bicornual configuration. So it is like a fusiform dilatation of both cystic duct and CBD CHD. So it will be like a bicornual. Okay. and type 6 is only the dilatation of cystic duct rather than the CBD. Now, among these, 1B, 1D, and 2 are not associated with abnormal pancreatobiliary duct junctions. We also see form first, which means patient have abnormal pancreatobiliary duct junction without any choledochal system. Again, this question, order of structures in the portal triad from superior to inferior. So we all know that portal triad in hepatoduodenal ligament. So superiorly to the right, there will be a bile duct. To the left, there will be hepatic artery. Posteriorly, there will be portal vein. Now, after dividing the right and left individually at the hilum, from superior to inferior, what is the order? The order is bile duct, hepatic artery, and the portal vein. So, as I said, this is the free margin of the hepatoduodenal ligament. This is the right side of patient. This is left side of patient. Anteriorly to the right, we find bile duct. To the left is hepatic artery. Posteriorly is the portal vein. And if we go to the level of hilum, bile duct comes anterior most, and this I think most of you will agree who has done liver resection or who has assisted a liver resection. We see the hepatic ducts most superiorly. Then comes the divided right and left hepatic arteries, and posterior most will be the portal vein. So the answer is from superior to inferior, bile duct, hepatic artery, and portal vein. So which artery has to be taken care during reconstruction of post-cholecystectomy biliary stricture? It's gastroduodenal, retroduodenal, left hepatic artery, or the right hepatic artery. The answer is the left hepatic artery. This is taken from Strasberg's vascular-biliary injuries paper. So the classical bile duct injury following laparoscopic cholecystectomy involves a segment of CBD, a segment of CHD, into which the cystic duct is entering. So at this level only, most of the time, right hepatic artery will be going behind, and that is also injured. So like this. Okay. So now we all know that 3 o'clock and 9 o'clock position, few arteries will be running, mostly coming from above, few coming from below. So coming from below will be GDA and supraduodenal arteries, but again they will be injured. The only artery going to the right side without injury will be this arcade or transhilar arteries from the left hepatic artery. So if you injure the left hepatic artery, right hepatic artery is already injured. 3 o'clock and 9 o'clock position arteries are also already injured. This arcade also, transhilar arterial arcade also will not receive any blood supply. So while reconstructing bile duct injury post cholecystectomy, we need to take care that we don't injure the left hepatic artery. That is why we don't recommend circumferential dissection of the bile duct. We just wanted to reach the hilum, open the bile duct along the umbilical portion of the left hepatic duct, see that it is in continuity with the right, then do an anastomosis without much handling of the left hepatic artery. So regarding the primary sclerosing cholangitis, which among the following is a false statement? IBD. So this question was in relation to inflammatory bowel disease and primary sclerosing cholangitis. IBD is seen in 75% of the patients who have primary sclerosing cholangitis. 15% of primary sclerosing cholangitis have lifetime risk of cholangiocarcinomas. The incidence of primary sclerosing cholangitis increases to the max in the 4th decade and then it decreases. Smoking is protective and decreases cholangiocarcinoma. The answer is smoking is protective for primary sclerosing cholangitis, but those patients who have primary sclerosing cholangitis, if they smoke, their symptoms may be less, but they tend to develop more of cholangiocarcinomas. The others are true. The maximum incidence of PSC is in the 4th decade. 15% of those who are PSC will have cholangiocarcinomas during the course of disease. 70 to 75% of the PSC patients will have concomitant IBD. Most of them will be ulcerative colitis. So, few things which we need to know. So many questions can be formed in this inflammatory bowel disease and primary sclerosing cholangitis. So, as I said, smoking is associated with primary sclerosing cholangitis plus cholangiocarcinoma. But smoking is protective for some symptoms of primary sclerosing cholangitis. Now, if we see a combination of inflammatory bowel disease and primary sclerosing cholangitis, most of them will have ulcerative colitis. Most of them will have pancolitis, but they will have rectal sparing, and at the same time, they will have backwash ileitis. Though they have pancolitis, they tend to have a less severe disease. If it is a Crohn's disease, it is rarely associated with small bowel only Crohn's disease. Okay, it will be usually a large bowel and small bowel combination, or just large bowel Crohn's disease. Though we do not see small bowel only Crohn's disease in primary sclerosing cholangitis, if such patients require pouch, they tend to have more pouchitis when compared to that of non-PSC patients undergoing pouch. There is though the patients with IBD PSC combination, they have less severe IBD disease, they tend to have more incidence of colorectal malignancies. Now, a patient with IBD and primary sclerosing cholangitis, if the colon is retained, then there is a risk of recurrence of primary sclerosing cholangitis post liver transplantation. Okay, it is confusing. That is why so many questions can be found in this combination. I will just repeat. 70% of IBD PSC patients will have IBD. Most of them will be ulcerative colitis. Now, amongst them, they will have a less severe disease. They will have pancolitis. They will have rectal sparing and backwash ileitis. Small bowel only Crohn's is not seen, but pouchitis is more. Though it's a less severe disease of colitis, they tend to have more colorectal malignancies. If colon is retained during liver transplantation, the chance of recurrence of primary sclerosing cholangitis is more. Which lymph node is not removed in surgery for carcinoma gallbladder? The options were 12P, our HDL portal group of lymph nodes, 8 is common hepatic artery group of lymph nodes, 13A anterior pancreaticodural lymph nodes, and 13B posterior pancreaticodural lymph nodes. We usually do not remove the anterior pancreaticodural group of lymph nodes. So this is how it looks like. We do extended cauterization and then remove the posterior pancreaticodural group of lymph nodes. We also take down the common hepatic artery group of lymph nodes. We also clear off the station 12, which is the HDL group of lymph nodes. This is because of the pathway of lymph nodal spread, which is usually cholecystoceliac, cholecysto superior mesenteric, and cholecysto retropancreatic. It doesn't spread through the anterior pancreas. Again, the question for percutaneous transhepatic cholangiography. This question was again taken from 6th edition of Lungart. The options, which among the following is false? Done below 9th rib to avoid lung injury for the right side. 15% will have serious complications. Multiple needle attempt is needed in non-dilated CBD. The success rate of access is 60 to 95%. The answer is only 3% of them will have serious complications. If it is a dilated system, success rate is 95%. If it is an undilated system, success rate goes down to 65%. Again, if it is an undilated duct, definitely it will require multiple punctures. Key is we can give a single incision, but we can change the direction through the same skin incision, and then we can do multiple punctures inside. So the next question is again question. We need not find evidence for this answer. So which is the least useful for portal biliopathy associated with cholangitis? Nasobiliary drainage, PTBD, ERCP and stenting, and shunt procedure. So if we see this superficially, we will think that nasobiliary drainage or PTBD is never described in portal biliopathy. But the most important thing which we need to see is cholangitis. Whenever cholangitis is there, first and foremost, we require biliary drainage. And shunt procedure does not provide any biliary drainage at all. So nasobiliary drainage, ERCP stenting, and PTBD definitely gives biliary drainage and relief from cholangitis. So the least useful in case of portal biliopathy with cholangitis is upfront shunt procedure. Moving on to pancreas, the most difficult ERCP is seen in. Again, this is a technical question. The options given were Billrod 2, acute pancreatitis with papillary edema and periveterine diverticulum, proven by GJ, particularly in non-bariatric surgeries and bypassing bariatric surgeries. See, in Billroth, Rowan by GJ and Rowan by gastric bypass, which is done for bariatric, we require enteroscopes. Okay. In acute pancreatitis with papillary edema and periveterine diverticulum, we will be thinking like, why in acute pancreatitis we will do ERCP. If it is acute biliary pancreatitis, very early with cholangitis, ERCP is recommended. So in that situation, we actually have certain things like pre-cut and pancreatic duct stenting, which will enable us to cannulate the CBD. Now, difficult biliary access is defined as the inability to achieve selective biliary cannulation, not pancreatic cannulation, selective biliary cannulation by standard ERCP techniques within 5 minutes or 5 cannulation attempts, or failure of access to the major papilla at all. We are not able to go to the major papilla at all. So, both in Billroth, in Billroth 2, Roux-en-Y, and bypassing bariatric surgeries, you will require an endom scope, not side viewing scope. Sometimes you require an enteroscope also. But the most difficult one will be bariatric surgeries, because even if we have an enteroscope, we need to go down 150 to 200 centimeters where JJ will be there, and from there we have to come back. So single balloon, double balloon enteroscopes require at certain areas it will be an acute angulation, and it is going to be very difficult. Most difficult ERCP will be for bypassing bariatric surgeries. So transoral ERCPs are very difficult. Instead, new modalities like transgastric, we will do a laparoscopy. We will hitch the remnant of stomach to the parietal wall, through which a small opening can be made in the parietal wall, and enter that. Then do a side wing endoscopy. Highest diagnostic yield of cystic pancreatic neoplasms are usually in the EUS biopsies. Amongst the following, least is with CT biopsy. CT we do, biopsy we don't do because of the risk of spread. Next is MRI, next is EUS. EUS cyst fluid aspiration, lots of mucin and clots will come, so the diagnostic value is less. These days we have a forceps which can pass through the small 19 French working channel, 9 French working channel of EUS thing. So EUS with fine needle biopsy is promising and upcoming, and has the maximum diagnostic yield when compared to that of MRI or CT or EUS FNA. Now, post-procedure complication, post-ERCP pancreatitis, which among the following is a false statement? Temporary stent prevent pancreatitis? Yes. Non-ionic low osmolar contrast injection at low pressure? Yes. Rectal endomethacin is beneficial either during the procedure or immediately post-procedure? Yes, it is beneficial. Acinarization of MPD should be avoided. See, there is nothing called as acinarization of MPD. Acinarization of pancreas should be avoided. You are entering into the pancreatic duct bed when you forcefully inject. Acinarization means second and third order pancreatic duct is involved. So that is called as acinarization rather than MPD being acinarized. Okay. So the answer there is acinarization of MPD. Acinarization is there, but MPD is not acinarized. Now, there are few risk factors for post-ERCP pancreatitis which can be patient-related or procedure-related. Female gender, those who have sphincter of OD dysfunction, is not drained properly, even if contrast goes into the pancreatic duct. Those patients who have IPM, and because contrast which can go in can be accumulated there with the mucin secretion, not allowing it to get drained easily. Previous or recurrent pancreatitis patients. Procedure-related, when we use pre-cut or endoscopic sphincterotomy, difficult cannulation and main pancreatic duct dye injection, all these may predict chances of developing post-ERCP pancreatitis. Best investigation to predict pancreatic insufficiency. Fecal elastase, fecal fat. I actually don't know the entire options. I have just added secretin CCK test. And amongst all this, secretin CCK test has got the best investigation to detect pancreatic insufficiency, but the most commonly used is fecal elastase test. Now, the disadvantage of fecal elastase test is it can identify it only in the later stage. So, the test for exocrine pancreatic functions can be classified into indirect test and direct test. Indirect test means fecal fat quantification, which can be done with radio-labeled carbon along with triglycerides. Now, non-invasive test and invasive test. The non-invasive test is measuring serum trypsinogen and enzymes in the feces like elastase and chymotrypsin. Most commonly used is elastase. Now, invasive test is you do an endoscopy, cannulate either pancreatic duct, cannulate the ampulla, or keep sample collecting instruments in the duodenum close to the ampulla, and then stimulate them by giving CCK, stimulate them by giving secretin. Lung test is actually, rather than stimulating, giving a specified meal. So these definitely can identify early stage because we are collecting the sample close to the ampulla. If it goes through the feces, few of the enzymes can be digested and may not reflect or may not give an idea about early disease. But this will give the idea about early disease. Now, secreting enhanced MRA or MRCP are the recent advancements which are still in experimental way. But if they come, they are non-invasive also. At the same time, we will be able to identify how much enhancement we get after giving the secretin. That gives us an indirect evidence of the exocrine pancreatic insufficiency. The next is an image-based question. In RAMS, radical, antegrade, modular, pancreatosplenectomy. So what happens in this? We divide to the right of SMA. Remaining pancreas is lifted up. Actually, this much exposure won't be there. I have just given for easy identification. So to orient oneself, SMA is retracted above. Pancreas is divided here. This is the bed of ramps. We are seeing one vein entering into the IVC. We are seeing another vein entering into this vein. So what is this vein which enters into the vein which in turn enters into the IVC? So the answer is adrenal vein. So left renal vein, this can be gonadal vein. Lumbar vein, actually we won't see. This is aorta. SMA, in between SMA and aorta goes the left renal vein and drains into the IVC. So the adrenal vein drains into the left renal vein. So when we go for distal pancreatosplenectomy, there are three planes in which we can do distal pancreatosplenectomy. The classical or the red line for distal pancreatosplenectomy is keeping the gerotus fascia intact. Going just above the gerotus fascia or fascia of treats, that gives the standard distal pancreatectomy. Now, most of the tumors will involve gerotus fascia. So in order to achieve a good R0 resection, we remove the gerotus fascia and also the perinephric fat, keeping the adrenal intact. So that forms the anterior ramps. And few tumors may involve adrenal also, in that we remove adrenal also and remove the perinephric fat and gerotus fascia. That becomes the posterior ramps. What is DPCAR? DPCAR is distal pancreatectomy, celiac artery resection. This is done for few tumors of body of pancreas which involve celiac axis. This was an extrapolation from Appleby procedure in which the tumor of stomach is involving or the lymph nodes are involving the celiac axis. So which among the following regarding DPCAR is not true? Ischemic hepatitis happens in 10 to 15%. Ischemic gastritis happens in 15%. Graft from aorta to proper hepatic artery helps in preventing ischemic gastropathy. Can be done only in select patients, but not all patients of body of tumors of pancreas. See, actually, when graft is placed between aorta and proper hepatic artery, this will reduce the incidence of ischemic hepatitis rather than ischemic gastritis. Okay. So celiac axis origin from aorta should be free. Though the tumor involves celiac axis, if the junction of celiac axis and the aorta is involved, we cannot go beyond that, cut the anterior wall of aorta and then reconstruct. That is not possible. Celiac axis can be involved, but origin with aorta should be free. GDA and replaced right hepatic artery, which arises from the superior mesenteric artery, should be free. Body of pancreas tumors involving celiac axis, definitely they should be subjected to neoadjuvant therapy, which can be chemo or chemoradiation. Only then, this select patients who have some response, either stable disease or good response, should be subjected to DPCAR. Now, in DPCAR, we divide splenic artery, we divide left gastric artery, we divide common hepatic artery, and then we take the celiac axis also. Now, the entire liver will receive the arterial blood supply through the pancreatoduodenal arcade, through the GDA into the proper hepatic artery, but sometimes this may not be sufficient. So 15% will develop ischemic hepatitis. For them, we can supercharge the GDA, supercharge through the graft placed between aorta and common hepatic artery stump. Now, left gastric artery is very important artery for supply of stomach. In this, only the right gastric artery and right gastroepiploic artery will be preserved, whereas left gastric and left gastroepiploic artery will be taken down. So 10 to 15% can develop ischemic gastritis. So that has to be taken care caution should be exercised while dissecting in the region of right gastropyloric artery or right gastric artery. Just like that, we cannot divide them. So moving on to the last portion of HPV transplant, only 3 questions were there, not a contraindication for liver transplantation. So again, this is taken from a table in recent Bloomgard. So basically, they are asking if the recipient or the patient with cirrhosis or HCC who is awaiting transplantation, if he or she had one of these malignancies in the past, they cannot be a candidate for liver transplantation. The options were recently diagnosed melanoma, current renal cell carcinoma, breast cancer diagnosed 2 months back, and seminoma 10 years back. So seminoma, testicular cancer, which occurs 10 years back, is not a contraindication for liver transplantation. So there are few tumors, because after liver transplantation, we will be given immunosuppression. With immunosuppression, these tumors can recur very fastly. So those tumors which can recur at a very high rate include bladder carcinoma, sarcoma, melanoma, symptomatic renal carcinomas, myelomas, and non-melanoma skin cancers. Intermediate recurrence rate, we can see breast cancer, colon cancer, and prostate cancer, whereas low recurrence rate include testicular cancers, uterine cancer, thyroid, and lymphomas, incidentally discovered renal tumors. So indication for liver transplantation and cirrhosis are all of the following except. In the previous question was contraindication, this question was for indication. Spontaneous bacterial peritonitis, single episode of variceal bleeding, hepatic encephalopathy, and intractable ascites. Like SPB, hepatic encephalopathy, and intractable ascites all come in decompensation, whereas single episode of variceal bleeding is not an indication for liver transplantation. Recurrent variceal bleed is an indication for liver transplantation. So indication for referral consideration for liver transplantation, adult patients with cirrhosis include hepatic decompensation, intractable ascites, which is not responded to medical and diet therapy, recurrent variceal bleed, and spontaneous bacterial peritonitis. So this question was asked. I actually don't know the exact answer. I also don't know whether the options quoted here are right or wrong. The question which was given, discussed in our group was criteria for liver failure or the graft failure after transplantation, and the bilirubin was given on post-op day 2, day 4, day 1, day 4. So honestly speaking, I don't know the answer for this. I don't know whether the options given were also correct or wrong. If someone knows exact question and exact options given, you can get in touch with us in the INI SS group so that I will see to that and find the answer definitely. Okay. That brings us to the end of recall discussion of HPV portion in INI SS 2024. So this was actually an extrapolation just to find whether was this the question, early allograft dysfunction, presence of at least one of the following within 2 to 7 days of surgery, serum bilirubin greater than or equal to 10, INR greater than or equal to 1.6, ALT greater than 2000. All these 3 are criteria for early allograft dysfunction, which are not primary non-function. So, but the options given were totally different. I was not able to identify any answer related to this, both in Bloomgart, Sabiston, Shackelford, or any papers related to that. So, kind request is anyone knows the exact option, exact question, please get back in our WhatsApp group. I will definitely try to find the answers. Thank you. Thanks for the patient listening. So that brings to the end of my presentation. So I think the live YouTube and this recorded Zoom meeting will be useful. Were there any questions asked in live YouTube? Actually, I don't have an access for that. Anyone from DocTutorials admin can help me out Right, my presentation is over, and yeah, I got a message. See comments of this, like we will end the session. Okay, we don't find any questions there in YouTube also. So thanks for the patient listening. If any doubts, we can definitely get back into the our WhatsApp group. Thank you. Signing off.